Welcome, everyone, and thank you for joining our virtual voyage of the Aging and Memory Loss Roadmap Education Series. We are grateful to have so many people here. My name is Nancy Koppelman, and I am the co-director of outreach at the Center for Alzheimer Research and Treatment. Today, we are presenting the first part, Roadmap to Dementia Diagnosis. A little background, the Roadmap series is a four-part comprehensive program about aging and memory. The series is a culmination of a couple of years pulling materials together. In being in the community and at neighborhood health centers, people and clinicians asked us to prepare this to help guide those people walking this road. A few details: you should have all received your electronic companion guide for today's presentation. If not, please email us and we'll send it to you. We will also send you an evaluation form for today's program. Please complete as we value your feedback, and please sign up to join our education registry. I would also like to introduce our speakers today, Dorene Rentz and Gad Marshall. Dr. Rentz is a professor of neurology at Harvard Medical School with dual appointments in the departments of neurology at Brigham and Women's Hospital and Massachusetts General Hospital in Boston, Massachusetts. She completed her degree in clinical psychology, neuropsychology in 1987 and has worked as a clinical neuropsychologist for over 30 years. She serves in multiple capacities as the co-director of the Center for Alzheimer Research and Treatment, the director of the Outreach, Recruitment, and Engagement Core, and clinical core director of the Harvard Aging Brain Study. Her research interests include early detection of cognitive and behavioral changes in preclinical Alzheimer's disease using novel cognitive assessments, as well as amyloid and tau PET imaging. On an international level, Dr. Rentz is involved in designing cognitive outcome measures for secondary prevention trials in Alzheimer's disease and is a proponent of validating at-home computerized assessments. Dr. Marshall is board certified in neurology. He is currently the Associate Medical Director of Clinical Trials at the Center for Alzheimer Research and Treatment at Brigham and Women's Hospital, Associate Neurologist at Brigham and Women's Hospital, Assistant in Neurology at Massachusetts General Hospital, and Associate Professor of Neurology at Harvard Medical School. Dr. Marshall has been site principal investigator for multiple clinical trials of amyloid-modifying drugs in Alzheimer's disease and is currently the site principal investigator for the Alzheimer's Disease Neuroimaging Initiative, also known as ADNI, DOD-ADNI, and the anti-amyloid treatment in asymptomatic Alzheimer's disease, the A4 trial. His research has focused on clinical correlate of activities of daily living and neuropsychiatric symptoms with multiple imaging markers and cerebrospinal fluid biomarkers across the early Alzheimer's disease spectrum, as well as developing novel, sensitive, and ecologically valid assessments for early functional changes in Alzheimer's disease.
Hi, everyone. I'm Dorene Rentz, and it's my pleasure to welcome you to our video recording of Roadmap to Diagnosis. I wanted to start by saying that more and more people are living vibrant lives into old age. Some of you listening today may be one of those people, but what we know is that the population is getting older and older, and in fact, there are 1.9 million people over the age of 90. I can remember when Willard Scott on the Today Show used to have a picture of someone who is reaching 100 years old, had a 100-year birthday. And that was such a rare event back in those days when we were kids. And now, because of the advances in medicine, more and more people are living older. However, there's no guarantee that those who live longer are actually going to be healthier. Next slide. I put this slide together quite a few years ago, and it's famous people that all of us can recognize who actually have died with Alzheimer's disease. I didn't know if any of you knew that Rosa Parks was one of those. Dear Abby, Henry Ford, Eric Erickson, Winston Churchill. And the point of this slide is the fact that, Alzheimer's disease is no respecter of persons. It doesn't matter who you are or what you've done in life, that Alzheimer's disease may impact you and your loved ones. Next slide. Therefore, it's really imperative that we know the earliest changes that are associated with Alzheimer's disease. And in part, we want to know this in order to receive early treatment. But we also know that memory changes even as we get older. I know that at my age, I don't remember things as well as I used to. But how do you differentiate normal aging from those kinds of memory changes that we really should be concerned about? One of the things that we know is that we all forget names. We can be watching television and see somebody appear in a movie and say, "What was that person's name?" That is a very common thing. We could walk into a room and not know what we went in there for. We could forget exactly where we parked the car in the parking lot. All of these kinds of things are really normal experiences as we get older, and not something that we should be concerned about. Next slide. In addition, though, we should know that memory loss and dementia can be prevented. That we could increase our exercise by walking daily, eat a healthy diet, get good sleep, 7 to 8 hours a night, engage socially with others, and do intellectually stimulating activities. These are activities that research has actually shown over the last 5 years can actually help maintain brain health and prevent the onslaught of, or slow down the onslaught of dementia. Next slide. But when are memory changes a concern? I think that we should be alerted to the fact that if we're getting lost in familiar places. I remember hearing patients say, we've gone to the movies every week, and last week my husband didn't know how to drive there. This kind of disorientation and loss in familiar places is a concern, and we should highlight them. If you begin to become more repetitive, or your loved one does, asking the same questions despite the fact that you've responded to them, these are things that we should also pay attention to because they're not necessarily normal. And when we begin to no longer take care of ourselves in the same way. So ask yourself these questions. Have you missed appointments or special family events? Are you forgetting birthdays that you would have never forgotten before? Are you putting things away in unfamiliar places, like putting the toothpaste in the kitchen cabinet or the keys in the microwave? Are you having trouble following traffic signs? Or have you been involved in more than one traffic accident or incident while driving? These are things that I think as we get older, we should pay attention to for each other, because some of these changes may not necessarily be indicative of normal aging. Next slide. I think we should also know that memory changes occur in stages. It isn't like as if one day your memory was perfect and then the next day it was impaired. Actually, memory changes are insidious. There are stages in which we know that memory is normal, and such as forgetting the name or what you went into a room for. But then there may be times when, as an individual, you begin to be concerned about your memory. Most people with subjective concerns are people who have lived with memory loss in their family. For instance, when mom or dad or aunts or uncles were diagnosed with Alzheimer's disease, you remember what those memory changes were like. And sometimes you see these things in your own life and you begin to have subjective concerns. Or as you get older, you have subjective concerns because you know that Alzheimer's disease runs in your family. These are times when you should not be afraid to talk to your doctor about these subjective concerns, or join a research study that's exploring the value of subjective concerns in relationship to memory. But don't ignore it anymore. In the past, when I was a young clinician, we were taught that people who were concerned about their memory were generally the worried well. And now we know that that may not necessarily be the case, that those of us who have subjective concerns may actually have some inside awareness as to what changes are really going on for us. But then memory begins to decline beyond the stage of subjective concerns, and you begin to have retrieval problems. That means having trouble recalling recent events. Many times the very earliest changes are that we might not be able to retrieve it on our own, but somebody gives us a cue and all of a sudden the memory comes rolling back. I think we should be aware that some of these mild retrieval problems are normal, but some of them are not, depending upon the consistency with which these problems are occurring. And then, of course, memory can decline into a major problem. This is when you totally forget recent events or forget details of conversations or the fact that a conversation even occurred in the first place. Obviously, when your memory problems become or reach that level, that is definitely when you want to get medical help and go to your doctor and talk about them. Next slide. So what should you do if you have memory concerns? Well, first of all, talk with your family or your friends. Ask them if they've noticed whether or not they've seen changes in you regarding your memory or your thinking abilities. Give examples of what you're concerned about. And obviously, discuss each of those things with your primary care physician. I know that primary care physicians have very little time nowadays, but don't let the primary care physician's time limits interfere with you discussing these issues with your doctor. You also should know that there are some medical issues that could cause memory problems, like if you have an infection or the flu. Sometimes medications that you're taking could interfere with your memory. You could feel depressed due to the loss of a loved one or other kinds of experiences that you're having in your life. That there's more than just Alzheimer's disease that can cause memory problems. And you should know that there are sometimes simple changes that the doctor can make in your medical regime that could bring you right back to your baseline and eliminate those memory problems altogether. But what is really important is that you have a medical evaluation to rule out any reversible medical problems. I know that there are people who have thyroid conditions, and when you have a low thyroid, that can interfere with your memory. Sometimes a urinary tract infection not only can make you look more forgetful, but it can also make you be more psychotic. That is, feeling that people are against you or out to get you. And yet, the second you treat that urinary tract infection, these medical situations disappear. So know that not everything that that is related to memory loss is Alzheimer's disease. And that's why it's very important to talk to your doctor about it. Next slide. Why get a diagnosis? I think it's really important that all of us today are real consumers and take care of our own medical care. Take charge of your future. You want to be able to participate in a clinical trial for Alzheimer's disease if that's the diagnosis that you're given, because we know that the first person to be cured of Alzheimer's disease is actually going to be in a clinical trial. You want to be able to maximize your health care and experience and get a diagnosis early. In fact, today we now have clinical trials that are preventative so that you can actually go into a prevention trial before you begin to have memory problems in order to help you get rid of some of the changes in the brain that are associated with Alzheimer's disease. As I mentioned before, you could have a condition that's totally reversible, and that's why you want to get the diagnosis. You also want to know what resources are available to help you maintain control of your planning and decision making. You want to be able to have things in place, such as healthcare proxy, power of attorney. You want to have all of these things available ahead of time while you're still fully capable of making decisions on your own. And what's really important is you want to have a care plan in place in order to help reduce stress for yourself and your family. You want to be able to talk to your loved ones about your concerns or your early diagnosis. Of course, understand research opportunities, and you want to be able to build a caregiver support system around you. Next slide. I think you should also know that those of us, as we are getting older, we all have concerns about whether we have memory loss that's consistent with Alzheimer's disease. In fact, every 65 seconds, someone in the United States actually develops Alzheimer's disease. So you should know that you're not alone, that we're all in this together. Next slide. So know the facts. There are myths and misconceptions that surround dementia. Are dementia and Alzheimer's disease the same? Actually, people ask me that question all the time. What's the difference between dementia and Alzheimer's disease? And what you should know is that dementia is the overarching umbrella that really refers to the clinical syndrome of changes in memory and changes in activities of daily living. But there are many causes of dementia. Alzheimer's disease is only one of them. You could have strokes and that cause a dementia. That's not Alzheimer's disease, but actually mimics a dementia syndrome. You can have Parkinson's disease, Lewy body disease, other kinds of dementing illnesses that have an underlying pathology that's different than Alzheimer's disease, but the clinical syndrome is still the same. That's why it's really important to go to a specialist like Dr. Gad Marshall to get a real diagnosis of what type of dementia you might have so that the underlying cause is treated. And is forgetfulness the same as Alzheimer's disease? As you've heard before me say, absolutely not. Sometimes forgetfulness is merely normal aging. Sometimes it's indicative of depression, or you didn't get enough sleep last night in order to be able to encode information. So while forgetfulness may be related to Alzheimer's disease, it's not always the same. And the other question that people ask, do all older people develop a dementia? Actually, no. There are some people who live into their hundreds, who develop no dementia at all. And then there are other people in their 50s or 60s who may develop early onset dementia. So dementia can strike at different ages, and that's why it's important for you and your family to be alert to those changes and actually get a medical diagnosis. And then, does dementia always present as memory loss? Well, I can tell you that Alzheimer's disease in general presents as memory loss, but not all dementias start with changes in memory. There are some people who have changes in spatial abilities, where they're getting lost, where they're not recognizing objects. There are some dementias that start with changes in language, where you have trouble getting out the words. So not every dementia starts with memory loss, and they can present in a variety of ways. That's why it's important to attend talks like this, so that you know that there are different ways in which dementia and cognitive changes can affect an individual as they get older. Next slide. So like I said, dementia is the overarching umbrella. And you can see here there are many different causes that can cause a dementia. Next slide. What we know and why we always think of Alzheimer's disease is because Alzheimer's disease is probably the most prevalent of all of the dementias. And in part, that's because our medical knowledge has caused people to be healthier as they've gotten older. We have treatable diseases now, like our hypertension, so fewer strokes. We have treatments for our cholesterol and for our thyroid, for other things that might actually cause a dementing syndrome. So Alzheimer's disease, for most people, they're relatively healthy. It's really their cognitive changes that become paramount. But there are percentages of other types of dementing illnesses, and many times um, different pathologies for dementia can commingle. And that means that you could have Alzheimer's disease and strokes at the same time. You can have Alzheimer's disease and Lewy body disease at the same time. And in fact, many African Americans have a higher prevalence of Lewy body dementia with their Alzheimer's disease. And that's why it's really important to go to a doctor and to get a more accurate diagnosis. Next slide. So what is Alzheimer's disease? Alois Alzheimer met Augusta Dieter in 1903 at the Frankfurt Asylum. And unfortunately, Alois Alzheimer had a terrible disease named after him, but it was because he cared about Augusta Dieter. And he realized that the changes she was experiencing weren't the typical schizophrenia that he was very familiar with in those days. So he followed her till the day she died. And then in 1907, he was able to look under a microscope at her brain and notice amyloid beta plaques and neurofibrillary tangles that are the hallmarks of this disease process. In fact, up until about 15 years ago, the only way that you could definitively diagnose Alzheimer's disease was in the same way that Alois Alzheimer diagnosed it. And that was by dying, giving up your brain, and looking under a microscope. Today, we have more radiological techniques that allow us to see these changes in the brain. We have amyloid and tau PET scans that allow us to see the same changes that Alois Alzheimer saw under a microscope. We can now actually see them within a PET scan. We have cerebral spinal fluid, in which that's a lumbar puncture where we take the spinal fluid out of your spine, and we can look at the fluid and see these changes in the brain. So there are now more modern ways to be able to look at Alzheimer's disease and to get a more definitive diagnosis. Next slide. But what happens when you have Alzheimer's disease? And what you can see from this picture is that there's a lot of destruction that goes on to the cells and the neurons in the brain that causes the kind of shrinkage that you can see in Alzheimer's disease. And what you also notice here is that the hippocampus, which is really responsible as a way station for memory and memory storage, is actually totally deteriorated in the brain, which is part of what is responsible for the memory losses that you actually see in Alzheimer's disease. Next slide. But again, like memory loss, there are different stages associated with Alzheimer's disease. And the very first stage is what we call mild cognitive impairment. And what this stage really implies is that you're still able to function pretty well in your activities of daily life. You might still be able to drive the car, still take care of yourself, still cook a meal, in fact, even still go to work. And the only changes that really are occurring are actually within your mild changes in your memory and thinking abilities. If you have a diagnosis of mild cognitive impairment, the question is, will you automatically develop Alzheimer's disease? And I think that not everybody who has these mild cognitive changes will go on to develop a dementia. Some people may stabilize because their underlying medical conditions can actually be stabilized. If you have mild cognitive impairment because you've had a stroke, or you have hypertension or high cholesterol, you can bring some of those conditions under control and stabilize so that you don't necessarily go on to deteriorate to develop a dementia. And what's really important to know is that if you have a diagnosis of mild cognitive impairment, there are a number of research studies that you can participate in that will help us to understand this stage of dementia more clearly. So for more information about that, we're going to encourage you to call us and let us know if you're interested in joining a research study that will help follow you more closely than your doctor ever could and help us to understand these mild cognitive changes. Next slide. So now it's my pleasure to turn this talk over to Dr. Gad Marshall, who's going to talk us a little bit more about what happens when you go see the doctor because you've had changes related to memory. Gad?
Thanks, Dr. Rentz. We're going to talk about what happens in a clinic. So the first thing, as Dr. Rentz mentioned, is if you suspect that you have memory issues or your family member does or a good friend, you should talk to your primary care physician. And what should you tell your primary care physician? Tell the primary care physician about the troubles you're having, for example, difficulties remembering appointments, difficulties managing some tasks at home, chores, errands, difficulties doing the finances, or difficulties finding your way outside of home. And so these are different symptoms that are important to mention to your primary care physician. And it's also important to talk to your friends and family about it to get information from them. Next slide, please. So how do you go about getting a diagnosis? So your doctor may or may not diagnose you right away. It may be a prolonged process. You may require several visits. You may need to see different specialists. And some medical conditions may be identified later on after enough follow-up time. You may not have a straightforward diagnosis. You may have mild symptoms initially. And so it is important to realize that this may not be answered immediately. Next slide, please. So who are the different type of specialists you may see, your primary care physician may refer you to? So there are different medical doctors, geriatricians, psychiatrists, geriatric psychiatrists, neurologists, cognitive or behavioral neurologists, and there are also psychologists or neuropsychologists like Dr. Rentz. These different specialists have different roles, and some of them overlap and some do not. So a neuropsychologist like Dr. Rentz primarily will perform extensive cognitive testing to give us a better idea of the type of cognitive deficits you have, and this will be primarily for diagnosis purposes. Sometimes neuropsychologists also intervene by treating patients with cognitive training and rehabilitation. The other specialists on the list will usually also diagnose, but manage the patient in terms of different symptoms that arise. And so it depends on the situation and depends on the availability near you. Next slide, please. What should you do before you go to an appointment? So this may seem like it's common sense, but you're stressed before an appointment like this. You have memory concerns. You're not sure what will happen, and so it's good to take a break, think about what you should do, and also have some support from a family member or a good friend who will help you go through this process. So it's important to be well rested before the appointment. Bring someone you trust with you. for a couple of reasons. One, because if you do have memory difficulties, you may not remember everything that's been going on. And so collateral information from somebody who knows you well is important. And then the other important reason is that if you're being assessed and you're stressed or you're anxious about what will happen, you may not remember everything that happened, even if your memory is not that bad, or you may not take notes. And so having somebody else take notes for you, ask questions that you intended to ask, and be there to support you is important. Another common sense one, just eat before the appointment so you're not, hungry, and you may, get irritable if you're hungry, or again, get more nervous. Again, bring a notebook to take notes. Bring a list of your medications. If this is a new doctor you haven't seen before, make sure that medical records have been sent to this doctor ahead of time. And allow extra time. These appointments may be long. It depends on the assessment, but some of these appointments may be a couple hours. So give yourself time for such an appointment. Next slide, please. What happens in these appointments? Of course, we do a physical exam, a neurological exam, primarily if you're seeing a neurologist, looking for any evidence of changes in your body that may relate to dementia, so or cognitive impairment. Some conditions may involve Parkinsonian symptoms, or you may have stroke symptoms, and so a neurological exam can help provide that information. Of course, we obtain a detailed history. We review the symptoms that you're experiencing, as well as other medical issues and medications, to make sure that we cover our bases there. And then we may refer you for different tests. So we may refer you for neuropsychological testing with somebody like Dr. Rentz, if the initial testing that we do in the office isn't sufficient to give us an idea of the type of cognitive deficits that are going on. We may refer you for a scan of your brain, a CT, an MRI, or a PET scan. We may refer you to undergo a lumbar puncture spinal tap to look at markers of, say, Alzheimer's disease in that fluid. And we may have a variety of questionnaires that we administer that also ask about daily functioning and mood and behavior. Next slide, please. So here's an overview of the type of scans that we use clinically most commonly. And for the evaluation of cognitive impairment, I would say the most commonly used scan is an MRI. What it does is show us the fine structure in the brain. It tells us if there's atrophy, like Dr. Rentz described earlier, tells us if there's any vascular disease, tells us if there is a tumor, sometimes slowly growing tumors that are benign, maybe pressing on important regions for memory in your brain, and may mimic a neurodegenerative disease like Alzheimer's disease. And so these are the kind of things we generally look for with an MRI. If you have a pacemaker, you may not be able to undergo an MRI. In recent years, pacemakers have been MRI compatible. However, you still have to shut them off temporarily to go into the scanner. And so you need your cardiologist to be involved. And so that is a major thing to watch out for. And also, say you're a veteran and you have shrapnel or so any iron-based metal in your body that could interfere with the magnetic scan and even potentially be a direct risk to you. So these are important things that you need to be aware of. And before you undergo an MRI, the MRI technicians will always review this with you. However, if you have memory impairment, you should have somebody who knows you well come with you so they can answer for you potentially if you forgot about some of these issues. Another thing is that you may just feel claustrophobic. You may feel uncomfortable in this tight enclosed area. The MRI scan is like a big metal donut, but it's kind of narrow tube, and your head is being moved into this narrow tube, and then you may feel confined. You have to lie down for about half an hour and lay pretty still. It's loud, and so some people may feel uncomfortable on a scanner like that. A CT scan or computer tomography is an alternative that may be more easily tolerated. It's X-ray based, unlike the MRI that's magnetic, because the CT is X-ray based and involves a little bit of radiation exposure. Although it is a pretty low amount of radiation, it's something to consider if that's a concern. On the other hand, it is much wider, and so it doesn't feel as confined as the MRI. And also, usually the scan is acquired over a much shorter period of time, 5 or 10 minutes. It does give you good images in terms of the structure in the brain, but not quite as sensitive as the MRI. But it is a decent alternative. A PET scan, or positron emission tomography, really looks at something else. So this is a nuclear medicine type of scan, and what we do with this type of scan is we use a specific contrast or radioactive tracer to mark different things in the brain. So the most commonly used PET scan uses a tracer called FDG, or fluorodeoxyglucose, glucose being sugar, and basically it shows us metabolism of sugar or activity in the area that's being imaged. And of course, we're focusing on the brain. And in the brain, when you have a neurodegenerative disease like Alzheimer's, there is decreased activity in a certain pattern in the brain. And so that's the kind of thing we can visualize with a PET scan that looks at FDG or glucose. There are newer PET scans that visualize some of the pathology in the brain of Alzheimer's patients. And the amyloid PET scans have been around for a while, and the first one was approved for clinical use by the FDA about 8 years ago. Unfortunately, it's not covered by insurance, and it's quite expensive, and so we don't commonly use it clinically. Tau PET scans are newer, and in fact, actually, very recently, a couple of months ago, the first Tau PET scan has been approved by the FDA for clinical use for tau severe. There are several other Tau PET scans that are still in development and only in research. But like the amyloid PET scans, these are not covered by insurance, even the one that's now FDA approved. And so we primarily use them for research. And these are, scans that can show us pathology in the brain as opposed to activity like the FDG PET scan or structure like the MRI or CT scan. And hopefully in the coming years, they will be actually covered by insurance and will be more widely used clinically. Next slide, please. So Dr. Rentz mentioned medical issues that we should watch out for. So there are different medical conditions that could lead to symptoms, cognitive symptoms. And this is a list of things to watch out for that may lead to more abrupt changes. Unlike a neurodegenerative disease like Alzheimer's disease that may develop over months to years, you may have an abrupt change over hours to days in your cognition or behavior. And these are the common culprits. So some medications can lead to these side effects. Most commonly, bladder type of medications used to treat bladder conditions, some of the older antidepressants, as well as some tranquilizers that are used for severe anxiety or sleep. And so it's important to have your medication list with you to review by the physician who sees you. Dr. Rentz also previously mentioned thyroid imbalance, and so either too high or too low of a thyroid can acutely cause cognitive changes or behavior changes. Infections, and most commonly a urinary tract infection or bladder infection. Dehydration, so as simple as that. You go out in the summer and you're walking and you don't drink enough fluids, you get dehydrated, your electrolytes get imbalanced, and you could get significantly confused. Poor nutrition, fatigue, and so it's important to review these kind of more general medical issues that may be stressors to your brain. Next slide, please. And here's a list of mood and behavior symptoms that also commonly occur with cognitive impairment. And we don't think that they're necessarily a psychological response, although sometimes they are, but they also are intrinsic to the condition. And so as you have changes in your brain, they may not only affect your memory and thinking abilities, they can also affect your mood, behavior, and personality. For example, in Alzheimer's disease, early on, you may see changes that are consistent with depressive symptoms, anxiety, irritability, and lack of motivation. Whereas later on, you may see symptoms like agitation. You may see psychotic symptoms like Dr. Rentz mentioned, like being paranoid or having hallucinations. And so these are also important symptoms to review as part of the evaluation for cognitive impairment. Next slide, please. Now, this summary slide here, courtesy of the Alzheimer's Association, goes over some of the aspects that I already mentioned. So the initial evaluation we described already in detail, and then what do we do after we diagnose you? There's a management. We review medications, as I mentioned, to look for offending medications and potentially remove them if possible. But we also treat you with medications that can help your memory, mood, and daily functioning. And there are 4 medications approved by the FDA for the use for the treatment of dementia due to Alzheimer's disease. And they have a modest benefit. You usually see a modest improvement in symptoms, and then they tend to wear off after 6 to 12 months. Of course, that is not a ringing endorsement, but people have very different responses. Some respond better than others, and some not as well. And currently, these are the medications that we can use to directly treat people who have Alzheimer's disease at the stage of dementia. Of course, as mentioned earlier by Dr. Rentz, we're working on a lot of different research studies to hopefully get better treatments on the market. We treat psychiatric symptoms. So I just mentioned the mood and behavior symptoms, and sometimes they're very disruptive. And so, excuse me, and so we try to treat them with medications that are available for more common psychiatric conditions like major depression or bipolar disorder, schizophrenia, and we employ those in dementia. And we do it more carefully because we're treating older individuals who may be more sensitive and have other conditions affecting them already. And then we also assess for acute changes in mental status that may be related to some of these medical conditions that we mentioned before. And we try to be proactive about treating medical comorbidities. In fact, particularly vascular risk factors like elevated blood pressure, cholesterol, diabetes can contribute to the development of dementia, specifically Alzheimer's disease, not just vascular dementia. And so it's important to be aggressive with the treatment of those conditions as well. And then there's another big aspect that's not traditionally medical, but rather some things that are common that may affect your daily functioning and social situation. And so if as you get more cognitively impaired, you may require more supervision from loved ones or family members, or of course, sometimes unfortunately, you may require supervision with an aide who comes into the house, or even go to a day program or end up at a facility. It is important to review the safety at the home. It's important to have advanced directives set up ahead of time for medical issues with a healthcare proxy, or for financial issues with a durable power of attorney. Dr. Rentz mentioned some measures for prevention or delaying decline of cognitive impairment, such as physical exercise, a healthy diet, and social stimulation. And then finally, the caregiver, a very important piece of this. When somebody becomes cognitively impaired and has behavior changes, if they're alone, they can really decline quickly. And if they have somebody with them, a family member or a close friend who can care for them, that can make a big difference, but it comes at a cost. The caregiver can be quite burdened in terms of financially, time-wise, and medically and behaviorally. They may there are studies showing that caregivers have more medical problems. They certainly have more psychiatric conditions because of the burden of caring for a patient with cognitive impairment. Educating the caregiver, providing support and resources for the caregiver is really important. And respite time. Sometimes they just need a break. There are programs where a patient can be taken care of for several days, up to a month even, for the caregiver to get a break, recharge and get back in there. And so it's important to think about the caregiver as well when you're treating a patient with cognitive impairment. And so I will end on this note and turn it back to Dr. Rentz. Next slide, please. You are still muted, Dr. Rentz.
Thank you, Dr. Marshall. um, so now that you know that it's important, now that you know what a dementia is and what Alzheimer's disease is and why it's important to get a diagnosis, you should also know that there are resources available to you. And one of the things that we put together for this particular roadmap series is our own pamphlet on roadmap to dementia diagnosis. And in there, you're going to find lots of wonderful resource information. All the slides that we just went over, you will find information there. I think that it's really important for those of you who are experiencing memory changes that you have resources available to you. Again, it's important to know you're not alone and that we're here to help. Next slide. So we, both Dr. Marshall and I, we work at the Brigham and Women's Hospital and the Massachusetts General Hospital. And we're part of the Massachusetts Alzheimer's Disease Research Center. And we have many different clinical research sites going on that offer research studies, both observational as well as clinical. And some of them are listed here. We belong to the Center for Alzheimer Research and Treatment, but there's also a center that does clinical trials over at the Mass General called the Alzheimer's Clinical and Translational Research Unit. So next slide. This is us at the Center for Alzheimer Research and Treatment. Please take note of the phone numbers and the email addresses. We offer a wide variety of clinical trials that you can participate in. One of the advantages of doing a clinical trial is that not only do you not feel alone, but you feel like you're contributing something. And I know that most of our research participants, they want, if they have a diagnosis, they want to be able to help the next generation. They don't want their grandkids to have to go through what they themselves are experiencing. And participating in a clinical trial is a way to not only feel useful, but to also help science, to help us to understand the disease and to come up with better treatments for the disease. Next slide. These are the people at the Alzheimer's Clinical and Translational Research Unit. What's interesting about their unit is the fact that they do proof of concept trials. So they're really looking at very interesting kinds of drugs and compounds to help at the stages of both mild and moderate Alzheimer's disease. You know, once you have the disease, we don't want to forget people who are in either these moderate stages of the disease or even in severe stages of the disease, because we want to be able to make to improve quality of life as best we can throughout all stages of the disease. And so these are the people at, we call it OCTRU, that are actually doing that kind of work. Next slide. But as you know, Alzheimer's disease isn't the only dementia. Dr. Brad Dickerson runs the frontotemporal dementia unit, and this is a type of dementia that actually affects people early on in life, so in their 40s or 50s, and it begins to impact people who have changes in their behavior. And there's help for that type of dementia as well with Dr. Brad Dickerson and his unit. Next slide. And then there's also a specialist, Dr. Steve Gompertz, who really specializes in the dementia with Lewy bodies and Parkinson's disease. And again, these folks not only give excellent clinical care, but they also have clinical and observational studies that are open that you can participate in as well. Next slide. And then finally, we don't want to forget the people who have vascular disease. And Dr. Anand Viswanathan is actually looking at vascular disease and runs clinical trials related to that as well. Next slide. Obviously, COVID-19 has really impacted all of the research efforts that are occurring, all of our clinical trials. However, we're beginning to gradually bring people back for clinical research. Um, there are also some studies that can be done online so that we can still continue to follow people with memory changes as well. So please don't hesitate to contact us. We'll let you know when we're actually back and doing research full-fledged, and we hope that you will participate with us. Next slide. So this is the end of our series. We have various different roadmap education series going on. This was the one you participated in, was the roadmap to dementia diagnosis. We also have a series on research participation, caregiving, and prevention. So please feel free to be in touch with us if you want more information on any of these aspects of our roadmap series. We have brochures available for all of them, and we can even come to your senior centers and give these education series as well. Next slide. So thank you to everyone who helped us in putting this particular roadmap series together, and we hope that we can be in touch soon. Thank you very much. I guess one more thing. Here are the email addresses of the people if you have questions and you would like more information, as well as if you want to schedule a memory test, an educational program, or to even receive our quarterly newsletter. Thank you for attending the Roadmap to Diagnosis.